Thank you to SAGES for the opportunity to present our work today. Our study is focused on the role of preoperative high-resolution manometry in predicting dysphagia following laparoscopic Nissen fundoplication for refractory GERD. No disclosures. Manometry has often been routinely utilized in the preoperative setting to assess the degree of fundoplication, often as a means for optimizing reflux control while minimizing adverse sequelae, including that of dysphagia. Dysphagia in particular is a known potential outcome of fundoplication that has deleterious effects on patient quality of life. Among these include malnutrition, weight loss, reoperation rates of up to 10%, as well as endoscopic dilation rates of up to 25%. Oftentimes, this dysphagia is transient in nature, resolving within 3 to 6 months post-operatively. There have been a large body of evidence that has failed to demonstrate conventional manometry is a reliable predictor of surgical outcomes. These are just a few of the many studies which have demonstrated such results. For instance, the Booth study of 117 patients demonstrated that at 1-year follow-up in post-Nissen patients, the outcome of dysphagia was equivalent regardless of the presence or absence of dysmotility on conventional manometry preoperatively. High-resolution manometry, in contrast, utilizes Klaus plots to demonstrate the spatiotemporal relationship of bolus transit as it's traveling towards the lower esophageal sphincter. The Klaus plot in the right inner subset demonstrates a normal manometric study. However, to your left, you can see an area of high pressure zone in red, and in the white oval region, you can see elevated IRP. The metrics we will be discussing further today include IRP and DCI. IRP, or integrated relaxation pressure, is the mean of maximal 4-second relaxation of the lower esophageal sphincter during a 10-second course of swallowing initiated by upper esophageal sphincter relaxation. DCI, or distal contractile integral, is a measure of the vigor of peristaltic contraction, incorporating elements of the amplitude, duration, and length of contraction. There have been a few studies which have demonstrated the use of high-resolution manometry. Among these include the Wilshire and Yamamoto study, both of which demonstrated higher IRP levels among patients with post-Nissen dysphagia on long-term follow-up. Therefore, the objective of our study was to further assess the role of high-resolution manometry in the preoperative setting to assess surgical outcomes of dysphagia as well as quality of life among patients receiving laparoscopic Nissen fundoplication for refractory GERD. Our study was focused as a retrospective analysis of patients between July 2011 and December 2014 at the University of Vermont in Burlington, Vermont. All patients were over the age of 18 years, and of the 146 patients in this cohort, 52 met inclusion criteria. Reasons for which patients were excluded included the presence of perisophageal hernias, as well as conventional manometry, or poor patient tolerance of high-resolution manometry requiring abortion of the procedure. In addition, there was one patient who was noted to have an intraoperative esophageal cancer. Follow-up was performed at specific time intervals of immediate post-op within 4 weeks in clinic, short-term 3 months in clinic, as well as long-term over the course of approximately 3 years over the phone. The GERD health-related quality of life questionnaire was applied as a validated measure to assess symptom progression over these time points. Among these symptoms included heartburn, dysphagia, odynophagia, bloating, dietary modifications, and the effect of utilizing anti-reflux medications on quality of life. Each symptom was scored on a scale of 0 to 5, 0 indicating the absence of symptoms and 5 indicating incapacitating symptoms affecting quality of life. A score of 2 or higher was indicative of dysphagia. Our study sample was notable for a mean age of 50 years, 73% female predominance, as well as a 58% rate of pre-existing dysphagia prior to surgical intervention. Here we can see the progression of dysphagia post-operatively. Most notably, on long-term follow-up, we see that the rate of dysphagia declined to 22% in comparison to 47% preoperatively and 51% on immediate post-op follow-up. Of the patients who had preoperative dysphagia, 61% had resolved symptoms by long-term follow-up, 22% had improved dysphagia symptoms, and of note, 6% of patients had new onset dysphagia, and 48% had no pre-op or post-op dysphagia. Here we can see that patients with persistent dysphagia on long-term follow-up had significantly higher basal LES IRP levels, which again is a measure of the ability of the lower esophageal sphincter to relax with swallowing. We also see a significant association between higher basal IRP levels and worse dysphagia, as well as quality of life outcomes on long-term follow-up. The existence of preoperative dysphagia is a known risk factor for the development of post-operative dysphagia. This has been widely characterized in existing evidence, such as the Wilshire study, which demonstrated a twofold increased risk. Our results were in concordance with existing literature, and here we can see that significant association. When assessing the amplitude and vigor of contraction, in other means, the mean wave amplitude and the DCI, we see that patients with persistent dysphagia on long-term follow-up had significantly lower amplitudes and DCI levels. Here we can see that the normal manometric ranges for mean wave amplitude is 43 to 152. The normal parameters for DCI are 500 to 4300. We can see here that although most of these patients who had persistent dysphagia on long-term follow-up fell into the lower normal range of these values, it draws attention to the fact that these parameters may not necessarily be applicable to post-Nissen patients as they may be to the classical use of manometry to evaluate swallow function. In conclusion, our study demonstrates that long-term post-Nissen dysphagia is associated with elevated basal LES IRP on preoperative manometry, which in turn demonstrates an impaired ability of the LES to relax. In addition, we see an association with limited peristaltic contraction as measured by lower mean wave amplitudes and DCI values. In concordance with all this, we notice that with the presence of preoperative dysphagia as a clinical marker of how the patients are presenting preoperatively, this also enhances the risk of post-operative dysphagia outcomes as well as quality of life outcomes. Of course, our study is limited by sample size and power, in addition to retrospective design and female predominance, in addition of limited variability in follow-up on post-operative checks. However, there are future directions for this work where we can go into further assessing the role of high-resolution manometry with regards to partial wraps, as well as further assessing the role of upper GI studies with solid swallow test evaluations to assess how patients can be managed with equivocal manometric findings. Thank you for your time.
A quick question about your study design. Did you look at other things other than the two you mentioned?
Yes, we did look at...
Because we get a lot of data from a manometric study. We get like 100 things on when you get, yeah.
Yes, we did look at all the parameters that are assessed on high-resolution manometry. Among these, looking at other values such as contractile front velocity, looking more into peristaltic breaks, as well as upper esophageal mean pressure values. And we were able to also find that higher upper esophageal sphincter mean pressures were associated with worse quality of life outcomes. However, the other parameters were not significantly associated with worse dysphagia or quality of life outcome scores.
The problem is that if you have many things that you're looking at, you know, obviously if you don't account and you don't correct for that multiple measurement, some of them will come positive. Did you account for your multiple analysis? Because each parameter that you check and you see whether it is significant, I mean, if it's important or not, is a separate studies in a way. So each one of those will affect, so your p-value has to be corrected in some way or form for all the things that you're doing. For example, you found these two positive. Maybe if somebody else looks at many other parameters, they'll get two something or one other thing that is positive. Did you account for that?
We did account for differences with regards to preoperative status, including esophagitis. However, many of the existing studies and the evidence that we have currently in literature have focused on IRP alone, and so that's why we were able to take it further with additional parameters as well as longer follow-up times.
Okay, second mic.
Brandon Oschlager from Seattle. I applaud you looking at your results. I have two questions. Number one is 52 patients, not a very big study, and so were some of the patients that were excluded because you did partial fundoplications, and what were your criteria to do so? And my second question is, what you have shown is that it looks like at least some of the patients in your dysphagia groups had a hypercontractile esophagus on some level, had a non-relaxing sphincter and/or a high-pressure peristaltic wave. So are you sure that there weren't just a couple outliers that perhaps were misidentified as really having a primary esophageal motility disorder where the reflux was secondary and may perhaps not have had an operation at all? Can you convince us that was not the case?
Our study, we excluded patients who had motility disorders such as aperistalsis that was noted on manometry. In addition, we excluded patients with paraesophageal hernias. One patient had esophageal cancer noted intraoperatively, and the majority of exclusions came from patients who had conventional manometry, as well as patients who were unable to tolerate high-resolution manometry, due to which the procedure was aborted. And all of these patients received Nissen fundoplication. There were no partials.
And the second question, I mean, did you look for outliers in those patients that had dysphagia that could be explaining your trends, and perhaps in retrospect you regret having operated on them?
There were no specific outliers that stood out to us. However, all of these patients were excluded if they did have a primary motility disorder and did not have an indication to proceed with the fundoplication. So all of these patients did have pathologic symptoms of GERD in addition to pH studies, probe studies, and 24-hour monitoring and upper GI studies if it was equivocal.